He currently serves as the medical director for the Alabama Department of Mental Health and Mental Retardation. With the time remaining after his presentation, we will host a brief question and answer session. So without any further ado, I will now turn it over to Dr. Powers.
First of all, thank you for inviting me. It's a pleasure to be here. And just as a little bit of background, updated background on my bio, I was indeed the medical director for the Department of Mental Health in the past, but now I'm currently the medical director for behavioral health for Viva, which everybody at UAB knows. I'm also a practicing neuropathologist over at UAB. And in that regard, we've been doing some work looking at the brains of individuals who die with COVID. Now, whenever I say that I'm a neuropathologist, it strikes fear into every physician's heart that somehow they're going to be shown a vertiginous-inducing blizzard of slides of brains, and I promise I'm only going to show two, just to prove that I'm actually a neuropathologist. So what I thought we would talk about today a little bit is generally what we think is the neurobiology of COVID and why it produces neuropsychiatric symptoms in some patients. And it's important to remember that the majority of people who get COVID do quite well, don't have much problem, but there is a distinct subpopulation that do develop problems, and in many instances they persist. And because of the sheer number of patients who are contracting COVID, for us as clinicians, it's going to be important. Moreover, for all of us who have continued our practice through the pandemic, we have also experienced the stress associated with managing during these times. And I want to particularly emphasize the behavioral health aspects in the medical professions. To give you an example of my conceptualization of COVID, I'll just give you just an example of a patient that we were discussing in one of our care management teams at Viva just the other day. And it's a 55-year-old African-American gentleman who has multiple chronic medical problems, was doing really well, has chronic kidney disease, pretty severe hypertension, diabetes, got COVID towards the middle of the fall, got pretty sick with it, wound up in a rehab unit, went home. Prior to that, he had never had any mental health problems at all. Was tending to all of his own businesses, taking care of all of his own medical problems. He lived alone. Following the episode of COVID and following his discharge from the rehab facility, things just did not go well. And so the next thing you know, he's been admitted with thoughts of harming himself and clinical depression. Never been depressed before in his life. No past psychiatric admissions. Now, of course, Viva has care management teams that are consisting of nurses and pharmacists and social workers. So our goal is to help him to be successful at home. But this is the kind of a fairly typical story that you hear of previously stable patients who now start encountering all kinds of difficulties. So what I hope to do is just describe a little bit of what I think is going on with this gentleman. I also want to sort of provide you with the newest data that we have on neuropsychiatric aspects of this. And then I want, and I hope that this will provoke a conversation both about what you as clinicians are seeing in the field, because that would certainly make me a wiser clinician, but also your thoughts on the other new challenge that we're all facing as physicians, and that's the infodemic, this sort of barrage of misinformation that our patients are currently trying to navigate, especially those of us, and we at Viva are very concerned about making sure that everybody gets their COVID vaccination, that the individuals that, especially in the high-risk group, get vaccinated. We'd also like to put our thinking caps on about what's this going to teach us about the next viral pandemic, because sadly there's probably going to be another one. And what can we do to help healthcare providers? I am I am seriously concerned about the mental health of providers. I spent time as the director of the PTSD unit at the Birmingham VA, and I'm well familiar with the impact of stress on individuals. Likewise, as the medical director for the Department of Mental Health, I manage disasters to include Katrina, the BP oil spill, as well as the tornadoes. And I am familiar with the impact of managing in a disaster situation. And by all measures, COVID has created a mini disaster situation for us healthcare professionals. So that's the objective. So let's go to the next slide. So if you want to conceptualize the behavioral health impact of this as being similar to a disaster, it's well known that anytime a population is subjected to a trauma as seen in a disaster, like for instance, the hurricane or the 9/11, that there is a significant psychological aftermath. So we should expect the psychological aftermath from this. And it's not only in symptoms like depression and anxiety, but it's also consumption of alcohol and the other problems that are associated with excess alcohol consumption, such as domestic strife, domestic abuse, and things like that. We actually studied the coastal populations looking at their mental health following the BP oil spill, which was a man-made disaster, and they showed considerable increases in self-reporting for both anxiety and insomnia and depression. And that's a theme that we'll talk about throughout the course of our discussion. The next slide. So I am neither a virologist nor an epidemiologist or an infectious disease specialist. I just want to tell you that up front. So my discussion of the virus is, if you want to have somebody explain the virus, Mike Sag is the guy, but I do want to talk a little bit about where is the ACE2 receptors in the brain. It turns out that there's angiotensin is an active molecule in the brain. There's ACE2 receptors, and interestingly enough, they're on the olfactory bulb, which is, of course, you get anosmia with COVID. They're located in the area where it's probably most important, in the ventral medulla, and in the region of the vagal nerve, the tractus solitarius, which manages various visceral sensory input, and in a part of the brain which is up towards it's more in the posterior region and the lateral region, in what's called the complex of Botzinger. And that is a group of nuclei that are sort of interconnected. They're really hard to find under the microscope, but they manage your respiratory drive. And it's thought that may play some role in some of the respiratory difficulties that patients get into. As well, you have ACE2 in the motor cortex, posterior cingulate, which is cognitive processing, and to a certain extent, some emotional processing, mesial temporal cortex, which is cognitive processing, substantia nigra, and is found on a wide range of cells within the brain, not only on neurons, but on microglia, astrocytes, oligodendros, and endothelial cells. And we think that what happens with COVID is, in some individuals, they get an endothelialitis, where the virus gets after the small blood vessels. And we'll talk about that in just a second when we talk about the neuropathology. On the next slide. So I'm not going to talk about the neurological consequences of COVID, but I'm going to put up a slide that just sort of demonstrates the kind of numbers that you're looking at. There's a range in both the patients with non-severe and severe disease. This is out of Wuhan, China. And I'm going to tell you, just as an alert, different groups look at different kinds of patients in different genetic populations, which means that they wind up with different numbers. And I have found tracing the numbers for these symptoms to be somewhat confusing. You'll see a lot of numbers all over the place. So what I'm going to try to do is just sort of give you a sense of what the numbers tell us, rather than talking about a specific group. For instance, we know that patients have trouble with mental status, they have trouble with headaches. The one complication that gets a lot of play is stroke. And however, stroke is, thank God, is not as common as you would think based on the reporting here. It is an important complication, but these other symptoms as demonstrated on this chart, and if you're listening in by telephone, it's things like headache is seen in 17% of people with severe disease, impaired consciousness in 15%, but the next slide does talk a little bit about stroke. And this is from a 38-year-old woman who had no known neurological history, had hypertension and obesity, because obesity seems to play some role in this, and reasonably well-controlled diabetes was found by her family at home down. Again, this is a 38-year-old, and was aphasic and hemiparetic. They brought her to the emergency room where she was noted to have a stroke. Here you can see in the middle of the field the mottled gray appearance. You're looking at the lateral aspect of the left lateral hemisphere, and that's an area that's been infarcted. Next slide gives you a coronal section taken at that level, and on the left side you can see the gray mottled area. There's general molding and swelling, which has ultimately what cost this poor lady her life. You can see there's left to right displacement with closure of the third ventricle, and she had substantial occlusion of her starting at her proximal middle cerebral artery, right where it took off from the internal carotid. She didn't have anything in her heart. She didn't really have advanced atherosclerosis, but she had COVID, and 3 weeks after having COVID, she had the stroke. She came to the hospital and she ultimately died. We're seeing, out of the 100 or so brains that I've looked at so far from the COVID, I've probably seen just a couple like this. It's not as common as people discuss it. However, it does occur and it can be catastrophic. Next slide. If you ask, and again, I'm a neuropathologist, so what have we found in the brains of these individuals? Going back to what may be driving some of these symptoms. This is from the most recent study. This was published 1 month ago, and this is actually a systematic review of 14 studies, and it's really kind of nonspecific. Really, the neuropathology in COVID, even though it generates a lot of neuropsychiatric problems, it's pretty nonspecific. Yeah, they have some swelling. About 10 or 12% of them will have either a small or large intracranial hemorrhage, microbleeds or scant subarachnoid hemorrhage. And then a lot of them will have nonspecific gliosis and hypoxic change. But interestingly enough, the hypoxic change is not as bad as you would think. That's what I thought I was going to see in all these brains. It was really severe diffuse toxic injury. And it is there in some individuals, but it's not as conspicuous as I thought it would be. Next slide. What do we see under the microscope? What you see is inflammatory cells around blood vessels. Mostly using the CD3 stain, we identify them as presumptive T lymphocytes. You'll see a lot of microglia, that's intrinsic brain inflammatory cells activation, a lot of it, especially in the brainstem, especially in the medulla. You'll see these kind of cortical microinfarcts that are hard to see. It punches out just a couple of columns of neurons, not much. And then you will see in a small number of patients some encephalitis, leptomeningitis like you'd see in herpes, but it's not really conspicuous. Now, why do I raise these issues? Because you'll image these people, and oftentimes it's worth imaging them, but oftentimes the patient has symptoms, but you don't find very much. And they don't necessarily have a lot of lateralizing signs, and that's because they've got things going on in their brain. They've got an inflammatory response, but it's really, in my opinion, hard to detect with our imaging. And that always says to me, just because I can't find it on my imaging doesn't mean that the patient's not experiencing it. And so just something to keep in mind. And by the way, when I'm looking for these things under the microscope, I have to hunt hard to find them. They're subtle. Okay, so let's move on then. That's the pathology. It's kind of pretty bland, except in the more spectacular cases like the infarcts. So what are we seeing with regards to the psychiatric manifestations? Well, let's start with the general population. You know, all of those folks who are walking through your front door, or your staff, what they may be experiencing, or the folks in your church who may be looking to you for advice on Sunday. What is the general population? This is from a CDC publication, and this is a credible CDC publication, in my opinion. And this, they had longitudinal data on people that they've been studying over time, and they asked the question, has anything changed since 2019? So you got people who responded positive in 2019 and people responded positive in 2020. And what you'll see is, and for those of you who are listening on the phone, there has been a shift to the right. In other words, the symptoms in the table all show increases. So for instance, anxiety, depressive symptoms have shown substantial increases. And by the way, before you become too alarmed with the suicidal thoughts, studies show that in Alabama, about 4% of the population per year will entertain some suicidal thought. It could simply be, I hate my life the way it is, I wish I weren't around anymore, but I would never do that because of my faith and my family. But that person would then be scored up as positive. So it turns out that a substantial number of people have these thoughts. But if you look at what happened in 2020, that number went from 4.3 to 10.7. Likewise, depression went from 6.5 to 24.2 of people endorsing depressive symptoms. So there has been a shift towards symptoms in the general population. Next slide. What about, this is a separate population that they've been studying longitudinally. What does it tell us about depression? You're seeing the same thing. And the number I wanted to call your attention to, you know, they broke it out mild, moderate, and severe depressive symptoms. This one just looked at depression. Here you can see that in the time before COVID, less than 1% of individuals were saying they had severe depression. During COVID, the number jumped to 5%. So in the general population, what we're seeing is, by my accounting, we're seeing a substantial drift towards more endorsement of symptoms. And you are probably seeing that in your office practice. Next slide. What about patients who have COVID? You know, if somebody developed COVID, whether they go to the hospital or don't go to the hospital, what would we expect with those individuals? And what would we expect from them longitudinally? And here again, what particular population you study is going to drive the findings that come out of this. So I'm just going to give you that heads up. I've looked at pretty much all the literature on this, and I'm constantly confused, which isn't that hard, but I'm constantly confused by this literature. The Rogers data is probably the best, and I'll give you all that reference. I have a little bit of a summary that we'll send around to folks who've logged in today, and they'll include some of the better references and where you can get them on PubMed. But here, as you're looking at this, the number of people who had COVID. Now, this data includes all of the coronaviruses, SARS, MERS, and COVID. It's an analysis of 72 studies. The reason I like this is that when the next coronavirus comes through, which it probably is, the numbers are probably also going to look kind of similar. And what you can see, just looking at symptoms like depression and anxiety, they're present in substantial numbers in both the acute phase and also in the post-acute phase. Memory problems are fairly common. The new term now, of course, is memory fog. The descriptions make it more like acute delirium. What it looks like in the post-acute phase is really more almost like a resolving delirium in individuals. Insomnia is fairly common, as well as irritability. And the thing that I want to call your attention to is fatigue. And in the SARS study, they identified at about 2 years, almost 20% of the people still complaining about something that sounded like chronic fatigue syndrome, of the people that were hospitalized with severe disease. So psychiatric symptoms are common in some individuals, especially people with severe disease. Next slide. What are some of the things that might impact whether or not you're going to have psychiatric symptoms? Well, probably there's a lot of individual variability on this. You know, it's your vulnerability to having the virus invade, especially invade the CNS. It's not clear that everybody who has COVID gets viral infection in the CNS. Also, how it impacts your immune system, because a lot of what we're seeing in the brain microscopically could just be the sort of the aftermath of the immune response. There is a substantial amount of interpersonal variability in the distribution of ACE2 receptors. So there's a lot of issues that could play in your vulnerability for getting CNS side effects, as well as the viral load. Next slide. Now, the new terms, by the way, long COVID or long haul COVID is not a medical term. It first started out in the British literature because a lot of patients said that they weren't getting any better, and they claimed that the doctors weren't properly addressing it, so the media started calling it long haul. The Del Rio article out of JAMA, he breaks it out, and this is very subjective. There's a big argument going over, you know, who has long COVID, how do you define it, etc. But there's the acute phase from 0 to 3 weeks or less, post-acute 3 to 12, and chronic more than 12 weeks, which I guess kind of makes sense. There's no reported neuropathology, by the way, in people who have chronic COVID. Those studies weren't done. In fact, the Chinese did almost no neuropathology on their subjects who died, did almost no autopsies. They tried to bury folks as quickly as possible. And there was no neuropathology of any substance reported out in the SARS and the MERS. So we're starting fresh with all this. Okay, so this is a study out of Michigan, looking at 1,600 folks who were admitted. So that's a special population. They were over the age of, most of them were over the age of 60. And then it was asking the question, what kind of symptoms did they have at 60 days? So this was a group that was older, was sick enough to be in the hospital, and they went back 60 days later and said, what are you going to see in these folks? And I broke this out into systemic effects, which is, you know, pulmonary, cardiac, and neuropsychiatric. And I apologize that the way they published the data was in numbers, so I'm showing you the real numbers. But you can see that a substantial number of people at 60 days were endorsing neuropsychiatric symptoms. Interestingly enough, only 28 of the original 1,600 needed to be treated, but many of them were endorsing symptoms. Next slide. If we could go to the next slide. Now, the one thing that everybody talks about all the time is anosmia and dysgeusia. And here is an example of numbers that seem to be all over the map. And again, I'm not a neurologist, and I'm not going to speak for my neurology colleagues. But it really depends on there's actually variation by nationality with regards to the rates. There's variation by comorbidities and COVID symptoms. So the numbers run anywhere between 7 and 68% for impaired smell, and 5 and 54% for impaired taste. Most of these folks actually regained that sense within about a month. Next slide. So we've looked at the general population. We've looked at folks who have gotten COVID and we either had post-COVID or didn't have post-COVID. So now let's talk a little bit about ourselves, the healthcare providers. My son is an ICU doctor. He's a cardiologist, he's an ICU doctor. And he was talking to me on the phone the other day, and he said, you know, Dad, he said, it gets really disheartening because I have patients in the ICU whose O2 sats are in their 60s, and they're telling me that they don't have COVID because they think COVID is a hoax, and they don't understand why I'm talking to them about intubating them when in fact, you know, they think that there's really not much wrong with them. And so not only is he battling the hypoxia, but he's also battling the misinformation in the patients themselves. What are the kind of, so this is a unique situation for us as physicians where, when you're dealing with disasters, no one would ever say, oh, there's not really been a real oil spill, so why are we worried about the physical or mental health aftermath of it? But in this particular instance, we're not only having to deal with the health-related issues, but we're also having to deal with public misperception about what's actually going on. And that's pretty darn stressful. What about us as physicians? If you read the literature and what the doctors are talking about, and the nurses, all the healthcare professionals, I don't want to fail to mention the respiratory therapists, right down to the folks who clean the rooms for us. It's, of course, fear of infection. None of us want to bring this home to our family or our friends. And none of us are free from our concern about that possibility. It turns out that they've done studies on isolation and quarantine. And when you have somebody who's been exposed and has to be quarantined, it turns out it increases their stress level. They learned that from SARS and from the equine encephalitis quarantines that were done about 10 or 15 years ago. The kind of mass casualty situations that are occurring in our emergency rooms and in our ICUs certainly is going to produce symptoms like PTSD, if not PTSD, anytime you have a mass casualty impact. I did a great deal of shelter work during COVID, I should say during Katrina, excuse me. And the one thing that I remember about going into the shelters and dealing with all of these traumatized individuals was a tidal wave of grief and loss that comes at you. And after a while, it just becomes overwhelming, no matter how well trained you are. And so these are stressors that we're all going to feel, no matter how well trained and devoted we are to the mission. There are the financial stressors. The AMA has a white paper out about 4 or 5 months ago, indicating that about a third of physicians had had a substantial loss of income during COVID. And childcare stressors, especially for our younger colleagues. And I'm going to get to that in just a second. Next slide. If you look at, they did a study, this is a meta-analysis of 115, this was published fairly recently, by the way, 115 studies looking at healthcare workers and with regards to what kind of symptoms they experienced when they got COVID. Here's the typical symptoms, looks pretty similar to what our patients are getting, to include headaches and dyspnea. Next slide. If you look at the psychiatric symptoms that healthcare workers, and this was all healthcare workers, it was doctors, nurses, respiratory therapists, you can see that there is a substantial number of symptoms that these individuals, and more than half had at least one symptom. So this when we contract the COVID, it is going to likely produce some stress related psychiatric symptom. That's not to say that we're going to have a diagnosis of major depressive disorder, but it is going to produce a symptom. This is out of, so that was looking at all of the coronaviruses. This is looking at healthcare workers in New York City. This was recently published, and this looked at 2,200, and it was done during the spike of the pandemic. And they found that a third of the healthcare workers met criteria for some disorder, to include depression, PTSD, and anxiety disorder. The next question they asked is, what are some predictors? And one of the major predictors was individuals who work in facilities where the management and leadership team didn't understand and the stress that they were under and didn't take all possible necessary steps to mitigate that stress. So better leadership probably produces better outcomes when it comes to the mental health of our colleagues. And I've seen that elsewhere, as a matter of fact, in other studies, not just that New York study. What are the sorts of things that our healthcare workers are dealing with, all of us. We're dealing with just the sort of the onslaught of death and sustained medical treatment. We're used to getting people better, and this is an illness that sometimes a lot of times doesn't get better. Not only that, we're watching our colleagues and our loved ones around us contract the illness. So there's bereavement and grief involved. There's also family stress, and I was asked a question, by the way. I was asked two questions that I should answer at this point. One is, have any of the studies shown an increase in OCD in patients with COVID, either in the patients who contract the COVID or the teams that are treating the COVID? I have not seen that reported in the literature, either from the biomedical aspect of it, of the biological drivers of COVID, or the psychological aspects of it, which is, there's so much stress that it might exacerbate symptoms. The other question was asked to me was, what is the aftermath of COVID on the family members of healthcare providers? And to address that issue, I hadn't seen that before. So to address the issue, I ran the literature to see if there was anything meaningful. And quite frankly, I didn't find anything, which I find to be very distressing. And obviously, that's something that needs to be researched fairly carefully. Financial impacts and societal stressors. And if we go to the next slide, well, isn't it true then that everybody's under stress, and the docs and the nurses and the respiratory therapists, it's no worse for them than it is for anybody else? Well, the Chinese actually looked at that, and what they found was that, no, it turns out that healthcare providers, in a distressed society, healthcare providers endorse more distress than even individuals in the distressed society. The other issue is, well, okay, is this just the frontline folks, the folks who are in the EDs or the ICUs? The answer is no. The Chinese also looked at that, and they found that the second-tier clinicians, people who are handling people over the phone and things like that, were also experiencing greater stress than you saw in the general population. Next slide. Going back to the whole issue of family stress in healthcare workers, we're healthcare providers, but we're also family members. And a lot of us are caregivers for our kids, for our aging parents. A lot of healthcare providers, have childcare that they have to deal with. A lot of our young doctors and nurses don't have a luxury of substantial backup in the event that they're no longer able to use childcare resources, or the caregiver that was in the home with them helping care for their children now has to be at home with their kids because they can no longer be there. So what was clear, in fact, there was one study that estimated that closing schools and pulling nurses out of the workforce would create a sufficient shortage that it would create more morbidity in the hospitals than leaving the schools open and having it propagate the virus. I don't know whether that's true or not, but those are the kinds of impacts that it was having on our workforce. So to answer the question, has it had a substantial impact on healthcare workers? Yes. And if you look at healthcare workers, they seem to follow the general population, which is anxiety, depression, insomnia, and insomnia. What are the sorts of things that seem to help mitigate stress on care workers that they've reported back? Organizational leadership support and adequacy of PPE, and having adequate workforce to support them. Next slide. What is the cumulative impact of all of the social disruptions that have occurred? Next slide. We don't know for sure, but we know that during times of financial hardship, the suicide rates go up. So in your practice, you should probably keep your ears up to that, especially in people who are financially distressed. The next slide has a little bit better data, and I'll make these slides available to you because I probably loaded too many slides and I want time for discussion. And I'm running a little late, apologize for that. This was not peer-reviewed published data. This was a white paper out of an institute, and this is the only data that I could find that I trusted. They found that there is an incremental increase in suicide rates in the nation for every incremental increase in your unemployment rate. They also identified an increased use of drug and increased use of alcohol abuse. I can tell you that the 911 services in the United States have been reporting an increased rate of call for putative drug overdoses over the last 6 to 12 months. The distillers are reporting an increased consumption of alcohol in the United States. And the rates of domestic violence calls among law enforcement are reported to be on the rise. So the aggregate societal stress does seem to have mental health and societal behavioral health consequences. Next slide. So finally, what's the role of the infodemic and by the way, infodemic is it's in the dictionary. It's a Merriam-Webster. It's a rapid and far-reaching spread of both accurate and inaccurate information about some topic, such as a disease. And that's in Merriam-Webster. If we could go back, it turns out that for instance, first of all, as doctors, I don't know about you. You guys may be doing better than I am. I don't have a clue what my patients are consuming with regards to online information. And there's a whole world out there of online sites that are offering information as if it is scientific. So for instance, and I've started doing some research on this, the research is not particularly good, but for instance, 82% of the online information about the COVID-19 vaccination is false and negative. So if your folks are going online to get their information, it's probably both false and negative. And it is a mixture of domestic groups or individuals who have a particular agenda and foreign actors that are spreading disinformation for a variety of different reasons. So it's sort of a new world for us physicians who keep our heads down and are so preoccupied with caring for our patients that we don't have the time to be surfing the web to figure out what our patients are reading. And what we have found that people who buy into conspiracy theories have a lot of problems with COVID and the vaccination. And the studies actually show that at the rate the anti-vaxxers are going, in another 10 years, more people will refuse vaccination than will accept vaccination in the United States. That was in a published study. Next slide. Next slide. What about demographic profiles of COVID skeptics? It's more common, and this is not a political commentary. I'm just telling you what the data shows. And this data has also been borne out in Kaiser Foundation data, Robert Wood Johnson Foundation data. They've all done studies on this. Younger people in better health who tend to be more conservative, tend to be politically conservative, that is, tend to be more skeptical. They're less likely to believe that people around them are going to get sick. And that's the odds ratio there that I'm putting up there. So you'll see the degree of skepticism. That skepticism, therefore, leads to diminished mask wearing or engagement in basic prevention strategies. And they're more likely to buy into conspiracy theories like the COVID virus was genetically engineered by the Chinese and is being used as a bioweapon. And you can see their risk ratio on that one is 6.38, which is substantial. So in addition to sort of struggling with all the other things that we have to deal with as physicians, there is this sort of surge of misinformation that is arguing against the use of what we know to be basic prevention intervention strategies that will help our patients and protect them. And those are all something that we just need to keep in mind as we're talking to our patients. we at Viva, like I said, we're very concerned about making sure that as many people as possible, as rapidly as possible, get their COVID vaccination, just like we are with flu. Next slide. So at that point, I am over time, and I do apologize.